Hello and welcome to Health Live at Seniors Today. If you're only seeing me today, it's because our guest doctor is going to be there with us any minute. His team has logged in and connected, but we are waiting for doctor to come in, and he's coming here.
Yes. Good
Hello,
evening. How are you
doctor.
today?
Good evening. So we have here with us Dr. Sony Mehta. I know we had earlier said that Dr. Anand Utere will be there with us, but he is stuck in an emergency and he's requested us to invite Dr. Sony Mehta, who's of course a very accomplished urologist. So welcome to Health Live at Seniors Today, Dr. Sony Mehta. Before we discuss the topic, etc., I'm going to introduce you to him. Dr. Sony Mehta is a consultant urologist and an andrologist with over 10 years experience of clinical experience in the diagnosis and management of a wide range of urological conditions. He is associated with the SL Raheja Hospital, which is a Fortis associate in Mahim in Mumbai. His practice focuses on the treatment of kidney, uretary, bladder stones, prostatic diseases, both benign and malignant, urinary incontinence in men and women, and urological cancers. He's also experienced in reconstructive and pediatric urology, providing comprehensive care across all age groups. In addition to that, he is associated with fairly advanced procedures such as uteroscopy, laser and open prostate surgeries, nephrectomy, cystoscopy, and various endoneurological treatments. Welcome to Health Live at Seniors Today. Dr. Mehta, how are you?
Yes, good evening. How are you today, sir?
I'm fine, thanks. So, the month of September is observed as Prostate Cancer Awareness Month.
Yes.
And as those of you who have assembled here are aware that we have discussed this issue several times in the past, because men, seniors especially, are vulnerable to get this disease. And we've requested our friends at SL Raheja to facilitate this session, and we have here with us Dr. Sony Mehta with us. So as always, do remember that these sessions are advisory in nature, and this session is being recorded on August 30th, 2025. So if you're watching this, a recording of this 2 years hence, do note that there could be be some advancements that you should keep a tab on. And so these sessions are advisory in nature, and a recording of this will be up on the Seniors Today website on Monday evening, so you can have a look at that. Don't worry about taking notes just now. And of course, as always, you can post your questions immediately after this session, after Dr. Mehta makes his opening remarks of around 10 to 15 minutes. And then you can ask your questions live, as always. Over to you, Dr. Mehta.
Good evening. Thank you so much for having me here. It's a privilege to be with all the seniors today. In fact, this is the age group who is very much aware nowadays compared to what it was maybe 10 years back or 20 years back regarding prostate cancer. I will be addressing in both English and Hindi, whatever is convenient to
English is better, sir. English is better, doctor, because we have attendees from across the country and from South India. So do speak in English. We could have a session later on in Hindi. Yeah, okay, over to you.
Sure. So prostate cancer as of today has a very, very major burden as a disease all over the India because of the newer technology, especially the screening test, which was detected maybe a couple of decades back regarding something called as prostatic specific antigen. Now, the burden of the disease is such because of the medical advancement, there are multiple options of treating prostate cancer, ranging from minimally invasive techniques to just chemoradiation to just active surveillance. There are multiple things which are involved over here. So as soon as the prostate cancer is detected in a person, we have a plethora of options to detect, to manage, and to make sure that the quality of life of the patient is very important. Okay, so to start with, screening of prostate cancer is most important, because with all the cancers, it's the same with the prostate cancer, that the earlier you catch the disease, the better. So screening is primarily based on something called as prostatic specific membrane antigen. It's a PSA, which is commonly known. It has got this thing is basically secreted or generated in common terms by prostate gland, and it is then circulated inside the blood. So in man, generally to find out a good portion of patients who may, I please underline, I who may have prostate cancer, PSA is a very good test. We have to screen all the patients rising right from the age of 55 all the way to the 75, as per the national and international guidelines. So we do this PSA blood test every year in order to make sure that if it is risen, we should subject the patient to further evaluation. Mind you, PSA as a blood test is only an indicator, or I would say in generally what I use as a term in my OPD is that it's just a messenger which tells you yes, you need further evaluation. Rise in PSA never ever proves cancer. There are multiple other things which cause rise in PSA, including infection, including bladder outlet obstruction, including multiple things. So nothing to worry if your PSA is high. The next step that you are supposed to do is contact a local urologist who is going to tell you what is to be done next. So now coming back to the burden of the disease, whenever a prostate cancer is detected with multiple lists of tests, we have lot of options today. Also, the way the peculiar thing about prostate cancer, and rather I would suggest for all the cancer, the main important thing that is there in today's world is to have a good quality of life. Number of years that the patient is going to live after diagnosis of prostate cancer is considerably large compared to any other cancer in the body. So that's why, prostate cancer is one of the slowest growing cancers in the body. Thus there are multiple options why as to we have so many options to treat it. Had it been an aggressive cancer of the body, then there are very limited options. For example, carcinoma of gallbladder, so we have a very short duration of time and we have to act very fast and aggressive. As far as the prostate cancer is concerned, based on the size, based on the spread, and based of the options, based on the organs that have been involved, we can have multiple options. Now, coming back to prostatic specific antigen, we have two options in it, free and total. Based on the ratio also, things are very relevant. Having said that, once we have detected that maybe the ratio of PSA to free to total PSA or the total PSA is high, anything more than 4 as per the international guidelines, we subject the patient to something called as multi-parametric MRI of prostate. Multi-parametric MRI of prostate is a contrast enhanced MRI. Contrast enhanced means you give a specific injection to the patient. Thereafter, we sequentially and serially scan all the images acquired by the MRI machine, and we evaluate whether there are any areas which require further evaluation with a biopsy. So there is something called as Pirates classification. Uh, so based on Pirates classification, we decide when to do a biopsy. Generally, Pirates 4 and 5 definitely biopsy is required. Pirates 3, yes, biopsy is always beneficial. 1 and 2 are safe to observe if other factors are within check. Now, once that thing is decided upon that the patient has Pirates 3, 4, 5 lesion, in earlier days we used to do ultrasound guided, transrectal ultrasound guided biopsy. Nowadays we have multiple MR fusion biopsies. Nowadays we have something which is very commonly practiced between advised between MRI and biopsy is something called as PSMA PET CT scan. PSMA PET CT scan verifies the diagnosis of the MRI, or rather adjuncts the diagnosis of MRI, and followed by which it also screens that in your entire body is there any metastatic cell which is there in and around. Nowadays, we have AI based PSMA PET scan, which are very, very sensitive. Thereafter comes the biopsy. Biopsy is an outpatient procedure, multiple options, transrectal, ultrasound guided, MR fusion biopsy. There are multiple ways to take the biopsies. Thereafter, we come to a diagnosis of prostate cancer based on the histopathological examination. Now, it's important to understand the range of aggressiveness of prostate cancer decides how far should we be aggressive with it. So let's suppose if it is a very, very basic, I would say we have something called as Gleason score based on the pathological examination. Let's suppose if it is a very basic level of cancer, 3 plus 3, 3 plus 4, something like that, organ confined, then we have something called as a cafeteria approach, meaning we have multiple options ranging from A, there's something called as active surveillance for 3 plus 3. B, there are something called as chemo radiation combination or independently just the radiation or chemotherapy. And thereafter, we have surgical options. Now, the reason we present so many options is because A, see, in today's world, the surgical options are extremely advanced as far as laparoscopic radical prostatectomy is concerned. However, eventually it's a surgery. So some patients may not choose to get operated. In that situation, our dear colleagues from medical oncology come and play, and they make sure that the patient is provided with one of the best options in chemo, radiation, or a combination of chemotherapy and radiation. Now, thereafter, if chemo radiation takes care of the malignancy itself, then things are monitored with respect to a fresh PSMA PET scan, blood test, and everything for any kind of recurrence. Surgically, the earlier days we used to do open radical prostatectomy. Nowadays, we have laparoscopic and robotic prostatectomies. Basically, we remove the entire prostate along with seminal vesicles, and we join the bladder to the lowermost portion of the urinary tube called as urethra in the process. The surgery is in nowadays fairly safe. Of course, with any surgical disease, there are some complications that is always expected. But with so much advancement in technology, especially robotics and laparoscopy, things are absolutely smooth these days. So this is the entire management of prostate cancer, which is limited to the prostate. God forbid if the prostate cancer has spread outside the prostate layer called as prostatic capsule. So then there are multiple options ranging from hormone deprivation. So what is hormone deprivation? Now, prostate gland or metastasis or the cancerous prostate cells, the metastatic cells, basically in the initial phases are dependent on testosterone, the male sex hormone, and eventually it becomes independent. So whenever it is dependent in the initial phases, you deprive the body of male sex hormone called as testosterone with respect to fantastic medicines, A, which are tried and tested for years, bicalutamide. There are other newer agents which are also available. Surgically, we can deprive the body of testosterone by removing both the testes called as bilateral orchidectomy. And there are various other treatments which are easily available as long as the cancer cells are in hormone sensitive phase. How do we know the cancer cells are in hormone sensitive phase? We will have to A, start the hormone deprivation treatment, including Degarelix and all those medications. See whether there is any kind of improvement on a PSA value and PSMA PET scans, anatomical and biochemical recurrence, and there that is how we come to know whether any kind of improvement is there or not. Thereafter, as far as the resistant phase is concerned, we have multiple agents, including chemotherapy, including abiraterone, enzalutamide, and all those things, all those newer molecules, which take care of all these kinds of metastatic diseases. So even in cases where there is good amount of metastasis to bone and other organs, the hope is not lost at all. We have multiple agents who actually prolong the life and give you actually a good quality of life as well. Thank you. So this is the overview. I am open for questions. We'll be happy to help.
Thank you, Doctor. Thank you very much for your opening remarks. We are, we've got quite a few questions in already, and I'm going to take one by one. One of the questions that has been asked is, Doctor, is prostate cancer hereditary?
Yes, so in hereditary prostate cancers, generally, if you have a first degree relative, the screening age, which I said that it varies from 50 to 55, we have to prepone it all the way to 40 years of age as per the guidelines. And we have to monitor PSA profile serially, annually. And if there is any rise, it will be prudent to do a multiparametric MRI of prostate to see if there are any lesions to check the biopsy. So there is definitely a hereditary role. So if you have a positive history with respect to your father or paternal uncles, then definitely you should get the screening early, right from the age of 4040.
Right. This is a question from Mr. Kiran Kapadia. He says, prostate uh, cancer. How does one come to know that you have a problem with the prostate, or it could be prostate cancer?
Yeah.
What are the early signs?
Unfortunately, prostate cancer is a very shy fellow. It doesn't manifest itself till the time it is advanced in cancer. Whatever that is available on Google, hematuria or blood in the urine, and all those symptoms are very late. So, frankly speaking, there is no particular symptom which is absolutely attributed to prostate cancer. That's why it is one of the disease, or rather one of the cancers which require early screening rather than relying on any kind of symptoms. So that's why screening from the age of 50 is absolutely recommendable to start right away. Hematuria is basically blood in the urine. It happens only when the prostatic cancer invades or passes through the outermost layer and gets into the urinary tube, and then it starts bleeding. So that is one of the symptoms. Earlier days, when the screening tests were not available, we used to get patients with a simple back pain, and if it turns out that their PSA levels are very high, and then when we do the bone scan, etc., and we figure it out that straight away there is metastasis to the vertebrae and all. So that time period, I mean, that kind of presentation is very late and very not very common these days.
Right. This is a question from Sham Mittal. He asks, what is the value of the PSA blood test if one does not have any cancer? And at what frequency do you recommend the test to be done? Is it after the age of 50 you mentioned?
Yes.
Is it a yearly thing, or is it twice a year? What would you recommend?
It is an annual thing. You are supposed to do it every year. And please do PSA profile, which is free PSA plus total PSA. We have seen many patients, and in literature there are many examples such as available, in which the total PSA is less than 4. However, the ratio is deranged, and thereafter when we chase it, it turns out to be a prostate cancer. So PSA profile every year from the age of 50 is the answer to the question.
And doctor, do you find people doing the PSA profile? Are there people above 50? Is that now acceptance increased about doing the test?
Absolutely. So all men generally in an urban setup are very much aware about the prostate and all those related issues. So there is in most of the hospitals in and around in most of the metros, they have something called as executive health checkup. They have straight away included PSA, as because PSA is one of the very good screening test. The sensitivity of PSA is very high. So it is very popular that people would want to take treatment for PSA. That's a very positive thing that is happening nowadays.
Right. There's a question from Meena Goyal who asks, does an enlarged prostate mean cancer?
Unless proved otherwise, it is the other way around. An enlarged prostate, generally your PSA might be a little high between 4 to 10, but mostly it turns out to be a benign entity, we have something called as benign prostatic hypertrophy, wherein the patients present with symptom of obstruction to the urine flow. And when we find out that the PSA is extremely high, of course we evaluate it. But unless proved otherwise, an enlarged prostate compared to other organs may have very less chance of malignancy compared to a small prostate.
Uh, Doctor, a couple of questions have come in, and these are linked to people who linked to cancer treatment.
Yes.
One is from Sheila Kohli. She asks, how good is hormone therapy for senior citizens?
Absolutely, absolutely recommendable, because let's suppose if you have a metastatic cancer and you are in a phase where your cancer cells are sensitive to hormone deprivation or this hormone therapy that we commonly call it. It is very very useful, and it is convenient, and it significantly blocks the cancer cell from metastasizing, and it may recede the cancer which has already spread to multiple organs. So absolutely recommendable, and with minimum side effects, and those side effects can be managed as well easily.
And another question, which is from Mr. Anil Singh, who asks, surgery or radiation therapy, which option is better?
If it is an organ confined disease, in layman terms, if the cancer is within the prostatic capsule, being a surgeon, obviously my answer to the question is surgery, but it depends on the patient's functional status. Let's suppose if I have a 70-year-old male, and let's suppose he has a history of stroke, he has cardiac issues, he has diabetes, not very mobile, restricted to the house. In these patients, even if the cancer is within the prostate, surgery might not be an option, because he might not be able to tolerate the surgery. So even in such particular cases, hormone deprivation is a good option. But even in a fully functional patient who is taking care of his day-to-day life, and socially and physically active, and the cancer is within the prostate, surgery is the right option.
Thank you. We have a question from Bomi, who asks, Doctor, should PSA tests be done if someone is in his 80s?
Now, as per the national and international guidelines, it is not recommendable. The reason that has been said that beyond 75 don't do a PSA test is because they say that at the age of 75, there are multiple other diseases or comorbidities, that is what we call, that the patient might be having, and PSA or prostate cancer might be least of his worry. However, if, like I told you, if an 80-year-old who's absolutely fully functional with respect to least amount of medical problems, and he is professionally active, there are such cases. In these patients, yes, PSA is recommendable. Absolutely. Also, at times we find that there are multiple spread out cancer in the body, what we call it as metastasis. So in these patients, when they present with metastasis, obviously we do a PSA to find out what is the original cause, where is it coming from. So these are the rarest of the rare cases where we do the PSA.
Right. Thank you. Doctor, you've already given the explained this, but I guess it's not clear. So we have a question from Mr. Jambunathan, who's 77 and from Bangalore. He wants you to again tell us what is the difference between PSA profile and PSA.
Yes. So generally the conventional PSA that we talk about, which is assumed to be anything less than 4, which is normal, is the total PSA. And when we have a free PSA, which is in an unbound form, that is known as the free PSA. So when we take the ratio, that ratio also indicates, if you look at your PSA report, that ratio also indicates your probability of having a cancer. So this ratio is not a very new thing, but at least it's like 7 to 10 years old. And this is the new thing which helps in detecting cancers in patients whose total PSA is less than 4. So that's why free and total, as in PSA profile, is something what I always prefer over just total PSA.
And this is a question from Gyan, who says, can a benign prostate be, can it convert itself to a to prostate cancer?
Yes. So two things. Yes, benign can get converted to prostate. Not a very, very common thing to happen, but yes, definitely. Also, I will give you an example. Conventionally, there is a procedure called as transurethral resection of prostate for an enlarged prostate, where we assume that the enlarged prostate is benign, we go for the surgery. And when we submit the specimen that we have resected out for the obstruction, not for the cancer, it turns out that a part of that prostate has cancer. So our assumption that there can be enlargement of prostate and may not have harbor malignancy is at times false. So then there is completely different management. So benign prostate, in spite of normal PSA and everything, and if it is subjected to a surgery or a biopsy, may have cancer. But asking for biopsy in all the patients who have normal parameters with respect to PSA and otherwise, that it doesn't help in going for a mass biopsy or something like that. So that's why biopsy is not recommendable unless MRI shows something or PSMA PET scan shows something, or if the PSA is extremely high.
Right. Um, Doctor, what are the ways in which one can prevent oneself from having prostate cancer? Of course, you mentioned about the fact that you need to do your periodic annual tests after the age of 50. But if somebody would not want to ever get prostate cancer, what are the recommendations that you would have, even including people who are seniors and somebody of, say, your age, for instance? Okay, how do you ensure that you don't get prostate cancer? What are the lifestyle changes or additions that one must adopt?
Yeah, the answer to this question is a little tricky in that there is not a particular lifestyle behavior which is attributed to causing prostate cancer as such. Now, generally, what has been followed or what has been available in the literature is that you have to maintain a very, very healthy lifestyle. You have to avoid all kinds of metabolic disorders, including diabetes, blood pressure, obesity. You have to prevent free radical damage, especially with respect to tobacco and alcohol. And all these healthy lifestyle is attributed to very, very low rate of prostate cancer. So basically the contemporary understanding is the free radical generation that happens secondary to all these activities may trigger prostate metaplasia, dysplasia followed by malignancy.
So what you're saying is, just have a healthy lifestyle,
Correct.
and that's about
We get a similar question for how do I prevent enlargement of prostate, just non-malignant prostate. So
right.
even though the answer for that is same, that sometimes it's difficult to act on the prevention except for preventing this free radical damage that we do. So there should be no metabolic disorders with respect to obesity, diabetes, blood pressure, all these things, and maintain a very healthy diet which is very high in maybe good amounts of fruits and vegetables, less of red meat and all those things. That is going to prevent the free radical damage.
Right. This is a question from Gyan. I'm not very sure whether you would, whether it's the right question to ask in this one. His question is: in some cases, hormone therapy does fully cure the prostate cancer, and then laparoscopic surgery and chemotherapy take place to cure. Why is it not advised to go into for a surgery in the first place?
If the chemoradiation cures it, I didn't get the question. Come again, please.
In some cases, hormone therapy does fully cure the prostate cancer.
Correct.
Then laparoscopic surgery and chemotherapy are advised to cure. So his question is, why don't we go for surgery right in the beginning?
Yes. So now what happens is surgery as such. Now the literature says there are two main complications that happens
So
after.
he mentioned, he just respond said, in some cases hormone therapy does not fully cure the
Acha
prostate.
does not fully cure. Got it. Got it. Got it. Got it. So now what happens is that is where I told that Yato spoke about cafeteria approach. So now what happens is whenever the cancer is restricted to the prostate, surgery is the number one way to go for you to get a cure. If you choose hormone therapy or if you choose radiation and thereafter if it metastasis, then surgery is not an option. So that's why surgery is something which one should go for in the first place if it is restricted to your prostate. Only thing at times which the patients might not choose is surgery has a risk of around 30 to 40% rate of urinary incontinence, as in leakage of urine throughout the day without your control. and close to 80 to 90% risk of erectile dysfunction. So when a surgery is offered in patient who have maybe 3+3 malignancy or 3+4 malignancy early, now aware patients might choose to avoid the surgery for these particular reasons, and that is where they choose hormone deprivation therapy. At times, it may take care of it completely, and at times, he may require laparoscopic surgery later on. So that's why, surgery, number one, absolutely indicated when the malignancy is restricted to the prostate. However, if the patient chooses to go for hormone deprivation therapy, it cannot be denied it to him. So that's where the choice of the patient or the informed choice comes in play. The patient has to choose surgery over other things.
Doctor, we've got a question. Is it true that prostate cancer, the occurrence is more in a country like India as against Western countries? And why is that so, if it is true?
No, I would suggest that, as per the contemporary literature, the incidence is almost the same. In fact, in Western countries, the PSA screening is more common compared to India. In Indian urban setup, absolutely, it's a very common thing, but not so in a village setup or something in a rural setup. In spite of that, the incidence of malignancies are quite high in India. So overall, if you unmask the actual number of malignancies which are not yet diagnosed, yes, Indian incidence is high, I would suggest, contrary to the assumption.
And would you say that the incidences of prostate cancer have increased in the last 10 years? Is it, from the time, say, you started practicing, for instance, is that something that you find has increased over the years?
Correct. So over the years, yes, it has definitely increased, but it is also important to understand the PSA screening program that has been going on for years has been yielding very positive results. So maybe that prostate cancer has been around for quite a number of centuries, and we might not have detected it if the PSA would have not been there. Earlier, the presentations were such that the patient would invariably present with metastasis. Nowadays, we have something called as organ confined disease, and that's where the surgical advances in prostate cancer have come into play. I'm talking about last 50 years or maybe something like that. So that's where we are seeing a lot of it, but then the tools to diagnose it, or tools to screen it, or tools to catch them early has also been very, very popular and common these days. So I would suggest yes, it is increasing. That is on the surface for yes.
Right, Doctor. I think we've answered quite a few questions. Just one final word to our attendees. Some things that they need to look at. One is, of course, as you mentioned, getting an annual test done for PSA profile. Any other thoughts that you would like to leave behind to the audience of senior citizens that is
Sure.
assembled here?
Any kind of urinary symptoms, do not ignore it. If it with respect to your urine flow, if it is with respect to you getting up in the night to pass urine, if it is with respect to any kind of urinary symptoms that you face, you have to meet your urologist. A simple consultation doesn't cost much, but if you avoid or ignore anything which is actually going on in your body, then that is going to be a big thing in the future. So, for the simplest thing, please don't go for Chat GPT, please don't go for Google, please don't go for all these things. It is important to interpret the science rather than Googling it. So, for the minimum symptoms that you have, please don't ignore it or try and take medications over the counter. Always contact the local urologist, and he'll definitely help you figure out if there is anything serious that is going inside your body.
On a lighter note, Doctor, until now you had Dr. Google who was causing a nightmare to the medical fraternity, but now you have Dr. GPT who also exists, who provides you know provides perhaps some good answers, but also could get a little off the mark. Is that something that you find a great hindrance to medical care, especially in the case of urology?
Absolutely. So, see, I'll tell you what. The AI, if I'm not an expert in AI, very honestly, but the AI is going to gather, which is the common knowledge that is floating around. So what happens is, let's suppose if I tell you that, I have a 4 millimeter stone, it's hurting, but I'm not able to, take it out. What do I do? So it's a common thing to, just advise, okay, boss, take so and so medications, or what we commonly tell each other, BRP ke nikal de, that kind of situation. But it doesn't actually work. It can lead to complications. Similarly, AI learns from whatever is floating around the internet. So let's suppose that is the AI's interpretation of it. So if the interpretation is wrong, then eventually everything boils down to one thing, and that is cancer. So if I were to have a testicular pain and I Google it, testicular pain, so next thing comes up is testicular lump, next thing comes is testicular cancer. So that kind of fear mongering is a very common thing that is happening secondary to the internet. So that's why, of course, it's a very good thing, very good intervention that has happened. But at the end of the day, the misguiding thing is a very, very common thing that happens even in Chat GPT and Google, both the things together. So absolutely, absolutely contact the doctor. For example, I'll give you another example. Let's suppose if I were to read 100 textbooks about rocket science, I'm not able to make a rocket myself. Because I should know how to interpret the science. Same things for lawyers, that they know how to interpret the law. Similarly, doctors know how to interpret the medicine. That's why, for anything that you feel that something is wrong, please visit your doctor immediately, and he's going to sort it out for you. Don't worry.
Absolutely, very well said, Dr. Sony Mehta, for these words. And this is why we exist as seniors today. We conduct these sessions every Saturday at 5 p.m. to get you up close with the doctors live, and where you can answer questions, because there's nothing like asking a question live to a doctor and getting the right advice. Of course, there's nothing like meeting the doctor in person, but not everybody is able to do that, or at least the first aid, I'm saying, the first help can come through webinars like these. So thank you very much, Dr. Soni Mehta, for this. And thank you to the team at the Fortis Hospitals, SL Reja Hospital, for doing this. Do remember, the Health Live at Seniors Today comes every Saturday at 5 p.m. You can pre-register for the health webinars so that you are informed about us well in advance. Also, do remember that Seniors Today, the magazine, comes out every 15th of the month. Last issue of the month, last issue, the August issue, as you know, was a special on Sholay, which completed 50 years on August 15th. And there is a daily newsletter which comes out at 6 a.m. So if you're up early, you can start your day with that. And of course, the Evergreen Club has its sessions through the day. And of course, we now have a special session on photography, which has just started, mobile photography, which you are aware about. And there's going to be a certificate course starting in very soon. There's going to be also a certificate course in karaoke singing, which is going to start very soon. So do keep in touch with Seniors Today and the Evergreen Club, the app, the website. Thank you very much once again, Dr. Soni Mehta, for taking your time on a Saturday evening, and when you are in the hospital. Yeah.
So one extra point I would like to make.
Yeah.
We all should be thankful that we all belong to India. This is the only country where an access to a super specialist is very easy, and you can get an appointment within few hours. So please use that opportunity. If you compare ours to any other developed country, it's a very, very difficult proposition to reach a super specialist. So please feel free to reach any of the super specialists with respect to any of the specialties that you would want to evaluate it for. Thank you.
That's a very, very important point, and I think all should be very thankful to the medical fraternity. While the advancements are there, they have networked hospitals that have come into the country, but clearly you can also have walk-ins, and I've seen these in hospitals where walk-ins are also, doctors do admit walk-ins in as you said, in the West or advanced countries, you would have to wait for a week or more for an appointment. So I think what you've said is very right, and perhaps that's the reason why you have Dr. Google and Dr. GPT in proliferating in those countries. But in India, you know where to turn to, and you get an appointment super fast. Thank you very much once again, Dr.